Welcome to ATCM, the Emergency Medicine channel. A 65-year-old male came to ER with complaints of spontaneous bleeding from the nose. Coming to our initial primary assessment, airway, the patient was able to talk one full sentence. There was no gurgling, stride or hoarseness, but there was active bleeding from the left nostril. So at this point of time, we went ahead with the Trotter's method. We asked the patient to pinch the nostrils and sit forward for 10 to 15 minutes. Coming to breathing, respiratory rate of 20 per minute, saturation of 98% in room air. Air entry was bilaterally equal. Coming to circulation, pulse rate of 80 per minute, BP of 180 bar 100 millimeters of mercury. Two large bore IV cannulas were inserted in this point of time. Coming to disability, GCS of 15 by 15, bilateral pupil equally reacting to light. Coming to exposure, the temperature was 99.6 degree Fahrenheit, GRBS of 180 milligram per deciliter. Coming to reassessment of the...
Okay. So, we have a middle-aged man. What is the age?
65.
65. So, elderly gentleman, 65-year-old male who has come to the ED with an episode of epistaxis, which happened 15 minutes. How long back?
Half hour, that's what.
30 minutes back. So, 65-year-old, 30 minutes back, history of epistaxis. So, what is our primary concern as an emergency physician? What is our major concern when a patient is coming with epistaxis? What is a major concern for us?
It's a compromisation of airway.
Airway, that is our priority, because depending upon the amount of blood, what will happen is that it can be an anterior or posterior. They might have aspirated the blood. So that is a major thing that you need to see. So airway is the first thing that is going to create problem in this patient, followed by circulation, but it will take time. But within 30 minutes, that is not going to happen. But airway compromise is the most important thing. So since you said that the patient is talking and there was no gurgling sound, we can assume that his airway is patent at this moment of time. And breathing, the respiratory rate was 24 only, and with a maintaining saturation. So our primary concern for any epistaxis of any patient that is coming is airway compromise, followed by hypotension. But to have hypotension, so how much amount of blood he should lose? Around 30 to 35% of blood loss should happen. Then only he will go into hypotension. So just like we classify the hemorrhagic shock, same thing only we are using here. So initially you have class 1, class 2. Some class 3 only you will have hypotension. So initially you will be having some amount of tachycardia. So this patient is only having an heart rate of around 80. So 80, and with the blood pressure was, how much was the blood pressure?
180 bar 100.
180 bar 100. Now the question comes whether you need to control this blood pressure or not. Why there is, my question here will be whether hypertension will cause epistaxis, or you are getting a patient with epistaxis having hypertension.
Usually hypertension is not a cause of epistaxis, but hypertension can cause the vessels to be fragile and can prolong epistaxis.
So the most important thing that you need to understand, it is not that increasing the blood pressure that is causing the epistaxis. Maybe the patient is already hypertensive. On seeing the blood, his blood pressure is shooting up, which is again prolonging the bleeding manifestation. Hypertension as such will not cause, there is no evidence for that, hypertension causing an epistaxis. So the reason behind, the patient might be already hypertensive, he had an epistaxis, and after seeing the blood, its blood pressure would have shot up because of the stress and all other factors. So that is most important thing that you need to consider. So many of the time we need to convince this to the surgeons who are coming and attending the patient, because the BP is high. That is why he is having epistaxis. So majority of the time it is not the reason, it is vice versa. So that is one thing that we need to see up. So whether, my question here will be whether you will treat this hypertension right now. 180 by 100 and he is bleeding, whether you want to treat this hypertension, either there is any active bleeding. Can you just quickly tell the local examination findings?
After the Trotter's method, we then reassess the patient.
So Trotter's method, after how long you will reassess the patient?
10 to 15 minutes. Please.
See, the Trotter method, the priority should be, you should be keeping the pressure, not just 1 minute or 2 minutes. After like at least 15 to 20 minutes only you should reassess. Then only some tamponade, whatever would have happened, some clot formation would happen. And again you are going for a DNA examination at that point of time. Whatever is happening, the clot, it will get dislodged and the patient will start bleed again. So that should be in a controlled. Now the examination should be in a very controlled environment, and you should be ready with all your anterior nasal packing materials, or you wanted some specialized packing materials considering whether it's a posterior nasal wall packing, or you wanted some tamponade. All those things should be kept ready when you are going for an examination at this point of time, because this time when you are going to see, sometimes the clot will get dislodged and the patient will start again having epistaxis. So my question here will be whether you want to control the blood pressure or not, because you have got that 15-20 minutes the patient is bending forward and 180 by 100. It is not 160 by 90 or 130 by 80, which is 180 by 100. You want to control the blood pressure or not?
We can control the blood pressure.
So what agent you will choose at this point of time?
We can go with the IV agents. Since
what I will say that maybe after 5 minutes you can again reassess the patient. Maybe immediately the patient had come with a lot of stress, everything, and so seeing the blood. After 5-10 minutes you can reassess the blood pressure. Then the blood pressure is still on the higher side. We can give any short acting agents. Preferably this patient, because tortoise method he cannot take anything orally. So definitely you need to give some IV agent. So maybe a labetalol is a very good choice. Hydrolysin IV previously was available here, but now it is not available. So you could have tried any of this agent, or maybe a simple furosemide also, a diuretic. That will also help in bringing down the IV furosemide also will help to bring down the BP. Metoprolol ideally decreases the heart rate, but it can also decrease the blood pressure. But the ideal agent will be a labetalol, which has got a 1:7 alpha beta proportion. Alpha 1 and 7 is a beta blocker. Is labetalol a selective or a non-selective beta blocker? It's not an alpha beta blocker. Selective or non-selective?
selective.
It is a non-selective. So nebivolol is a selective, carvedilol is a selective, but labetalol is not a selective one. So you have to be cautious when you are using it for patient with asthma. So that is one thing. It is not a selective. So 1:7 is the alpha beta ratio of labetalol that you want to remember. So that will be our idea. So the patient has come with epistaxis, you applied your tortoise method, you are waiting, you can reassess the blood pressure after 5-10 minutes. You still high, any of the short acting agents you can give now to bring down the blood pressure. So that is one. Maybe he might be having some amount of pain, that also can increase the blood pressure. Maybe some analgesics depending upon the patient's pain is there or not. Next thing, you have going to examining the nasal cavity. So before examining the nasal cavity, as I said, you should be prepared now if there is any active bleeding to treat that activity, getting your cauteries ready. If at all, if it is going to be a torrential bleed, you have to have the chemical cauteries also there, then the normal cauteries also available. Then your anterior nasal packing, maybe the Merosal pack, maybe a Foley's catheter for the, if it is a posterior. What is the percentage from anterior and posterior, which is more common?
Anterior nasal bleeding.
So how frequent it is? Majority of the time it is anterior. Very rarely you will see posterior. It's somewhere around 85-15% we can say. 85% of them it is from the anterior nasal cavity, and it can be from posterior, or it can be both. Where will you get both anterior as well as posterior? It will be more of a mucosal bleeds when the patient is on anticoagulants. There is a coagulopathy which is causing bleeding. We cannot say whether it is anterior, whether it is wherever there is a mucosa, the patient is bleeding from that mucosa. So that is what you need to keep in your mind. So then you go ahead with your examination findings. What was the examination findings?
We then did the local examination, but still there was active bleeding.
Okay.
So we again tried the reassess the BP. BP was still on the higher side. We have given injection labet at this point of time. 10 mg IV stat was given, and along with that, we went ahead with the Merosal packing at this point of time.
Okay. So Merosal pack, whether it will help for anterior or posterior?
Anterior.
It will help for the anterior. If it is posterior, from the history itself, you will come to know some extent if it is an anterior nasal bleed or posterior nasal bleed. The patient is actively bleeding from the nose, most likely it will be anterior nasal. And the patient is telling something is bleeding in the posterior and is bringing out blood through the mouth. So that might give you a suggestion that it's a posterior nasal bleeding. So these are the clues by which you can but the problem is that with tortured method, they will be just holding it. Whatever blood is coming out through the mouth, so you will be asking them to spit it out. So we don't know exactly whether it's an anterior or a posterior, but majority it will be anterior. Merosal packing will definitely help for an anterior nasal packing. So what is the advantage and disadvantage of a Merosal packing?
Disadvantage is that is contraindicated in case of traumas.
Okay. And how long you can keep a merosal packing?
24 to 40.
24 hours of body. Otherwise, it will can cause septal necrosis. So you have to be very cautious when you are using. Previously, we have all the ribbon gauze and all those things. We need to shape it. When we were studying, we were asked to do the nasal packing for all those things. But now, after the merosal, which has been there since last 15 years, so merosal is one thing which you can just insert it, just inflate it, and it will just blow up inside the nasal cavity, and it will give a tamponade effect. So that is one thing. After you initiated him on merosal nasal packing, and after that, what happened to him?
Then we reassessed. Then there was no active bleeding from the nose, and the BP came down to 150/100 also. So.
Okay. So what is why there is epistaxis? You have such amount of torrential bleeding happening. You get other area. You have a small facial laceration. But it's not bleeding to this extent. Why in the nasal cavity there is a torrential bleeding happening? What is that means you have to tell me regarding the anatomy of nasal cavity, blood supply of the nasal cavity. That is what I am meaning here.
So the most common cause is that due to dense blood supply, it is the little area that is more prone to anterior epistaxis. That is caused by both internal and internal carotid artery.
It is basically an anastomotic area of internal carotid artery and external carotid artery. Why there is so much blood supply to the nasal cavity? Because this area need to be keep humid. Because of this, there is a lot of blood supply to that area. Because we are breathing in and breathing out. So that is why there is a lot of blood supply to that area. So basically there is an external carotid artery and internal carotid artery. Both the major blood vessels are supplying to this area. So that is, as you said, the littles area where both this get anastomosed, and that is a very commonest area for the epistaxis. So what are the reasons why the patient is having epistaxis? Most common reason for epistaxis?
Most common reason can be any sort of trauma, nose picking.
Nose picking, that is the most common one, and especially in children and any other age group, and maybe around 60% of the patient, they would have had epistaxis at their lifetime, at any point of their life. It can be due to a simple upper respiratory tract infection, small mucosal rent, which is maybe we all had a cold, common cold. After that, we may be sneezing, and suddenly we can get some amount of blood. So that again, it's an epistaxis. So the most common reason will be a nose picking, direct trauma. Then it can be what else it can be? Other reasons for epistaxis.
The reasons can be any tumors, any infections like granulomatosis, rhinosporidiosis, like that.
So that's all very, very, very low in our listing, because these are all very, very, very rare things that is happening in our day-to-day activity. So then
drugs that can go.
Drugs, most important is anticoagulants. Any role for tranexamic acid?
No roles.
See, there is no proven role as such like what we see in our crash 3-4 head injury and all those things, but still you can give tranexamic acid. But evidences you ask, there are less number of evidences. How will you manage this patient further? So whether can we send home or whether he need to be hospitalized?
An elderly patient with this note, and we applied the merosal pack, so we can't send the patient home like that.
You have to risk stratify him. So how will you risk stratify? You said elderly, I accept. So there is no as such risk stratification for epistaxis. It is the clinician perspective whether you need to admit the patient or not. Second thing.
All traumatic.
Traumatic, okay then.
Multiple comorbidities.
Patient on antiplatelets. Here the patient was on dual antiplatelets. So there is always a chance that the patient can have a rebleeding. So that is again I wanted to observe him. So that is the other reason. So depending upon the comorbidities and how much time it took for you to stop the bleeding. So if you applied sometime after merosal packing, there can be oozing. Still there can be oozing. Posterior nasal bleed, you cannot send them home. The patient need to be inside the hospital. If it is posterior nasal bleed, how will you tackle?
We can go ahead with Foley's catheter.
Okay, can you just explain the procedure? How will you do? For suppose there is a left-sided nostril posterior nasal bleeding.
We will cut the tip of the catheter. We need to give local anesthetization, and then we will insert the catheter. Once the tip passes the posterior pharyngeal wall, we will inflate
the balloon
with air, and then we just pull 1 to 2 centimeter back.
Then pull it and it will give a tamponade effect. That is the basic idea. This bulb is going and compress the blood vessel wherever it is causing the hemorrhage. So that's what we will do for this patient. Okay. So Any role of antibiotics you wanted to give him?
Ideally, from guidelines, there is no indication for antibiotics. But if we are like Merocil packing, we are giving for more than 24 to 48 hours. It's better we send the patient with antibiotics.
Because if you're planning to remove it after 24 hours, don't need it. But here there is an active bleeding. Depending upon that, you can give a very simple antibiotic, a penicillin, augmentin, or you can amoxicillin, clavulanic acid, some gram-positive agent, which is very frequently seen in the nasal cavity. You can give that. And if the patient is on anticoagulants, then the treatment pattern totally changes. Then you have to just treat like the patient is having coagulopathy. Maybe you need to do a TEG. You need to see what exactly you need to transfuse, whether it is FFP, whether it is cryoprecipitate, whether it is platelets. Depending upon that, you need to decide what product needed to be transfused during that point of time. Then what happened to this patient?
We also kept a ENT consultation.
Okay.
They came and the site, and it was an anterior bleeding, and they admitted the patient.
They admitted the patient for observation. So the most important thing, you should not be removing that Merocil pack. You should not be removing. Once it is placed, it has to be placed. It is very one thing, it is very costly. And whatever tamponade effect you have done, it will be gone and the patient will start bleeding again. And that is not for you, that is for the other team. They should not come and see, let's see where is the bleeding happening. They should just admit the patient for time being, and maybe after 24 hours they can go ahead to the OPD and do a nasal endoscopy and see what exactly is happening, and they can decide further upon. Worst case scenario where you are not able to stop the epistaxis. So what is the answer for that?
The last resort will be embolization of the spinopalatal artery.
So that is the last thing. Previously it was a surgical, now because of the interventional radiology, it will be embolization of the spinopalatine artery. Fine. Anything else?
Most common cause of epistaxis can be age group is pi model, children and elderly. Children, that is nose pricking and respiratory tract infection due to dryness. Elderly, it is actually idiopathic, and some systemic cause of epistaxis are also there. Decreased production of platelets like leukemia, myelodysplastic syndrome, increased destruction like ITPs, inherited disorders, and drugs like antiplatelets and anticoagulants.
So the simple thing will be, if you are not getting answer why this patient had an epistaxis, just do a routine blood screening, routine coagulation profile check. We will be able to get something. If you are not able to, we can place it as you are an idiot. It's not idiot. You can make it as idiopathic, and you can, if you are not getting any cause, that is there for us. So that is idiopathic. Okay, fine. Okay, thank you.